Cervios is a system of implants and instruments designed for anterior cervical interbody fusion, or ACIF. Cervios was developed for the following purposes: to distract the disc space and restore normal disc height and physiological lordosis, thereby also widening the foramina; to preserve the integrity of the vertebral body end plates; to provide an optimal implant-end plate interface, thus considerably limiting the risk of subsidence into the adjacent vertebrae; to stabilize the pathologically unstable segment; and to support bone growth through the implant. The anatomical cage design, which mimics the vertebral end plates, provides high segmental stability. The large cranial and caudal contact surfaces reduce the risk of implant migration and subsidence. The Cervios cages are made of radiolucent PEEK material, that is polyether ether ketone. The cage incorporates 3 X-ray markers, here shown in red. The 2 anterior X-ray markers are longer than the posterior marker. Indications. The Cervios cage is indicated for mono and multisegmental cervical pathologies requiring segmental spondylodesis, including ruptured and herniated discs, cervical disc disease, instability, and spinal stenosis, and pseudarthrosis or failed spondylodesis. For multisegmental fusions, additional anterior or posterior fixation may be necessary. Contraindications are fractures, tumors, severe osteoporosis, major instabilities, and infections. The large implant surface has been optimized to match the average vertebral body anatomy. The large central hole makes it easier to fill the cage with bone graft or bone graft substitute such as Chronos. Chronos is made of beta-tricalcium phosphate, which will resorb over time and be replaced by new bone. The implant has a lordotic angle of 7 degrees. A number of small teeth that secure the implant between the vertebrae are located on the cranial and caudal surfaces. Cervios is available in both a curved and a wedge-shaped design to accommodate variations in vertebral anatomy and the surgical technique. The curved surface is indicated by an arrow and must be directed cranially. Both versions of the cage are 15 millimeters wide and 12.5 millimeters deep. 6 implant sizes are available in heights of 5 to 10 millimeters. For each implant size, there's a corresponding trial implant. The implants either come empty to be filled with cancellous bone or are pre-filled with Chronos. For this exercise, cages with a blue plastic insert are used. The following instruments are used for implanting Cervios: the Synthis Caspar distractor with an adjustable angle setting, a distraction tab, and a release catch. The 1.8 millimeter drill bit with T-handle and the screwdriver are used to insert the 2.7 millimeter screws for the Caspar distractor. The implant holder and depth limitator. The same implant holder is used for both the implant and the trial implant. The trial implant is attached to the tip of the implant holder and fixed in place by turning the wheel in the handle clockwise. The implant itself is attached in the same way. The depth limitator is attached to the implant holder by clicking it in place from the side. Before surgery, a first estimate is made of the appropriate height by comparing the Cervios radiographic template with the adjacent intervertebral discs on a lateral X-ray. This comparison provides a measure of the required implant size, which is later confirmed by using the corresponding trial implant. A 2-level discectomy and fusion will be performed using the cervios cages and additional fixation with a cervical spine locking plate. The anterior longitudinal ligament and anterior annulus are cut through to create a window for access to the disc space. The rongeur and the curette are used to prepare the disc space. The rongeur is used to remove the disc material, and the bone curette is used to scrape the vertebral end plates clean of all cartilage, taking care to preserve the end plate integrity. All osteophytes must be removed. With the drill and T-handle for the Caspar distractor, the hole for the distractor screw is drilled in the superior vertebral body. After removing the drill, the screwdriver for the Caspar distractor is used to insert the 2.7 mm distractor screw. The screwdriver is removed, leaving the screw in place. The process is repeated for the inferior vertebral body. The Caspar distractor is placed over the distraction screws, making sure that the settings are still loose. Now the distractor settings are fixed. The distractor tab is turned until the required distraction is reached. Care must be taken not to over-distract. The trial implant is inserted into the prepared disc space using the implant holder and depth limitator. The distraction can now be released to check the fit of the trial implant. Once the fit is correct, distraction is reapplied and the trial implant is removed. The appropriate cage is inserted into the prepared intervertebral space. The distraction then is released. The implant holder is removed by turning the wheel in the handle anti-clockwise. The settings of the distractor are loosened. The distractor is repositioned for the distraction of the next intervertebral space. The steps are repeated, and the second cervios cage is inserted into position. The distractor pins are now diverging due to the cages and illustrate the increase in lordosis. The cages should lie about 2 mm posterior to the anterior border of the vertebral body, and in the midline when seen from the anterior view. The cervical spine locking plate is used for additional fixation. A brief overview of the instruments used in this section of the exercise will be given. The official AO-CSLP course video contains a more detailed description. With the self-holding drill guide, a plate with 3 pairs of screw holes is picked up, using one of the middle holes by pressing the handle and activating the locking mechanism with the thumb. The plate is put in position over the levels to be fixed. There are 2 different self-holding cruciform screwdrivers. The 4.0/4.35 screwdriver, below, is used for the expansion head screws and the fixation pins. The 1.8 screwdriver with holding sleeve, above, allows the locking screws to be taken from the tray directly to the screw heads without any risk of them falling into the wound. The fixation pin is picked up using the self-holding screwdriver. This pin is used to fix one of the cranial screw holes of the plate in position. The same is done for the contralateral caudal screw hole. The drill guide is released from the plate by pressing the handle. It is repositioned in the free cranial screw hole, once again being locked firmly into place. The 3 mm drill bit with 14 mm stop is inserted through the drill guide. A hole is drilled until the stop is reached. The drill bit and drill guide are removed, and the 4 mm expansion head screw is inserted with the self-holding screwdriver. The procedure is repeated for the contralateral screw hole. The fixation pins are removed, and the procedure is repeated for the remaining holes. The screws must be flush with the surface of the plate to avoid damage to soft tissues. Now the 1.8 millimeter locking screws are inserted into the expansion head screws, using the 1.8 screwdriver and the holding sleeve. Once again, the screws are checked to make sure they're flush with the surface of the plate. That concludes this practical exercise using the Cervios cages. A clinical example shows a 55-year-old female with a monosegmental degenerative disc disease at C5, C6. There are posterior osteophytes and a loss of disc height. An anterior discectomy was performed. The posterior osteophytes were removed and the disc height was restored. Fusion was achieved with Cervios cages, pre-filled with Chronos.